So I'm going to talk about the colorectal surgeon's viewpoint. And the difference between what Richard and I do is Richard takes care of the girls, I take care of the boys. I mean, that's a difference, but it's a big difference. I think the other thing that's a little bit different is as a colorectal surgeon, we tend to see a lot more HIV positive disease. In HIV positive males with anal rectal disorders. And so I think there is actually quite a difference in the types of patients that we treat. This is the exact same slide that Richard showed, except mine's in blue and his is in gray. But again, 80% of women, I'm going to go through my epidemiology slides pretty quickly because Richard already covered most of it. Men have the exact same number. Richard said that, but he concentrated on women. In this study of Brazilian, Mexican, and American men, from the time of entering the study up until 36 months, about 80% have developed HPV. And just like women, it drops off quickly. So within 6 months after identification of the HPV in the genitals of these men, about 50% have cleared it, and then eventually 80% of men will clear it. So same numbers. Whether it's cleared or not is a little controversial. It may just be undetectable, kind of like we talk about HIV today. It may not be completely gone. It may be just undetectable, but it's no longer present on the studies that we can do. In HIV-positive patients, it becomes a little bit of a different problem. At any time when you take a cross-section of HIV patients and you look for dysplasia or you look for HPV, what you do is you find that about 80%, same number, will have dysplasia at that time, presumably the HPV disease. And what we think is going on here is that these are the people Richard was talking about who do not have a competent immune system. So we can't clear it. Well, not we. They can't clear it, the HPV patients. So it's a bigger problem in the HPV populations because they can't clear it at any time more men have this in their anoderm. Richard talked about the different subtypes, high risk, low risk. Certainly in the male population, and especially in the HIV population, I think the average number of HPV subtypes per patient is 6 now, where 20 years ago it was 1. And so it's become a more complicated world. The other comment I wanted to make was these are tendencies towards dysplasia. Most of us don't tend to treat 6 and 11, 16, 18 differently because 6 and 11 are less likely to become associated with cancer, but doesn't mean they're not going to become cancer. And 16 and 18 are more likely to become neoplastic, but doesn't mean that they're going to. So I don't think that most people subtype anymore. They just treat HPV as HPV. Again, the different manifestations, anywhere from asymptomatic infection to benign warts, dysplasia, and invasive cancer. That's what comes out of the HPV that affects the anoderm or the genitalia of the human being. I'm going to break each one of those down separately. Cancers, as Richard said, cervical cancer, almost all of it associated with HPV. 500,000 women a year in the world will develop it. Anal cancer, somewhere about 20 to 30,000 people a year develop it in the world. About 80% of that is associated with HPV, and then a variety of other cancers that are HPV associated as well. So big problem worldwide, affecting men and women pretty equally. I mean, I think most of us have thought of HPV as a female problem up until more recently, but now we're realizing it's both sexes. And now that they're getting a little bit better control over the cervical through Pap smears, it is becoming more equivalent in the effect in the healthcare fields. Diagnosis of condyloma, no-brainer, right? A patient comes in complaining of little bumps, it's got some itching, bleeding, irritation maybe with wiping, things along that line. You look at it, you see the warts. The problem is that warts do not cause pain. It's not a problem, but it's something you need to be aware of. So patients, when they come to me and they say, yeah, I've got these bumps and they're really painful, first thing I say is that's not the bumps. We need to find out what's causing the pain. And you got to look for ulcers, fissures, abscesses, or malignancies, the thing that we're worried about. Worried about going on and becoming cancer. A big symptom of cancer is pain, so you always got to look for that if a big complaint is pain. In the general population, about 1%, some studies as high as 2% of the general population will have condyloma in their lifetime. Relatively low, relatively easy to deal with. It is increased in homosexual males, and up to 25% of HIV-positive individuals in some populations, some studies, will have condyloma at the time you look at the examination of that cross-section. So it's much more common in the HIV population to get warts with your HIV and HPV infection. Again, I think speaking to the balance between the immune system and the HPV virus. HIV immunosuppressed patients can't clear it as much. They tend to have more of the manifestations of the disease with the warts, dysplasia, and cancers. billion treatments for it, as Richard said, some of them chemical, some folklore. I use a lot of imiquimod, which is Aldara, like Richard says, but I got a problem. Richard, I love when I have it. I don't love it, but it's nice when I have an HIV negative patient with warts because I think Aldara works really well. The studies unfortunately showed that Aldara or imiquimod only has about a 15% efficacy in HIV positive patients against an 11% efficacy with placebo. So it's not much in HIV positive patients, probably again because this works by boosting your immune system's ability to clear the virus. And since the immune system is screwed up, it probably doesn't work quite as well in HIV positive patients. So I still do a lot of wart surgery because it's difficult to clear from the HIV patients. I'm not going to talk about all the different types of surgeries, but the one thing they all have in common is a very high recurrence rate. Whether you get rid of it by burning it or freezing it, whether you get rid of it by dropping acid on it or cutting it off or lasering it, there's anywhere between a 30 and a 50% recurrence within a year, 3 months, 10 months. They come back very frequently. This has been shown to really be most likely related to the virus that's left behind in the skin after discussion. And so this really nice article by Ferenczi in '85 on New England Journal, he went and he cut warts out, and then he took the very edge of his margin after laser excision, and he biopsied it. And he found that 45% of these people had HPV at the margins of the excision. And if you're positive, you had a 67% recurrence rate. If you're negative, 9% recurrence. So the issue here really in the recurrence is the fact that there's virus left behind in the anoderm after you've destroyed what you can see. And that's the big problem. That's why we continue to have large recurrence rates. The concept came up, is there anything we can do about that recurrence? The first study that came out was actually in 1990 by Vance. And what he did was he excised the lesions with a laser. He then injected interferon, which then boosts your own body's ability to fight the virus theoretically, into the lesions. And then he actually did a couple of follow-up injections and then followed him up a few weeks later. And what he found was that he was able to decrease the local recurrence from 40% down to about 20%. So not great, but better. There's some question about whether this is just delaying the recurrence, because the longer you follow these out, the more recurrence that there is, but there does seem to be some improvement with the interferon. That was followed up by Fleschner out of Cedars back in '94. He followed people for about 4 months and again decreased the recurrence from 40% to 12% by injecting interferon after excising anal condyloma. Our own, you do need to know that there is some balancing literature on this also. There's several articles out there that says that interferon makes no difference, such as this one where they did some injections and then some follow-up injections for 10 weeks and didn't find any difference in the recurrence rates, all of which were about 60% at week 38. So it's a little bit of a question. In our own patients, when we looked at them, we were actually able to differentiate the different, we were able to find a difference as to the extent of the condyloma. So if it's relatively limited disease, you seem to have a bigger effect with recurrence being higher or persistent disease being lower, however you want to look at it, if you inject interferon. There's a benefit to injecting interferon. If it's very extensive disease, they both end up being about the same recurrence rates. So maybe we give interferon to people who have less disease and we might have a better effect on it. The problem with the condyloma or with HPV really leads into dysplasia. And this was really recognized first in the condyloma. Pathologists told us when they looked at these warts, we found some that looked like normal warts and some that had this plastic, funny-looking cells all the way up and down, and they had dysplasia within the wart. And if you look at warts, as Metcalf did in 1995, what you find that there's significant dysplasia beyond just being a wart in about 6% of heterosexual males and about 28% of homosexual or bisexual males. And actually, if you broke it down by HIV at that time, only 13% of HIV-negative heterosexual males had dysplasia in their condyloma, whereas 60% of HIV-positive homosexuals. The interesting thing is that the HIV-negative homosexuals fell in the middle somewhere. So this, I think, speaks to a couple of things. One is probably the subgroup of homosexual males have gotten into their community a more virulent strain of the virus that seems to cause more dysplasia. And then also, once you get into the HIV status, you start playing with the immune system and, again, allowing the dysplasia. So immune system, not only does it allow the HPV virus to persist, but it seems to allow more of a progression to dysplasia, and we'll find out into cancer also. So it's all about the immune system as far as this is concerned in our populations. So we have a pretty good understanding that HPV causes warts. We have an understanding that warts are associated with cancer through the dysplasia studies, and certainly if you have warts, you're more likely to get cancer. The line then became, back in the mid-90s, can we draw HPV straight to squamous cell carcinoma? And they started doing studies along that line, and papers like this started coming out in 1995, where they said, look, we've been following a bunch of normal anuses as part of our practice for a long time, and all of a sudden we're seeing cancers develop out of nowhere. And they're not going through a wart phase, they're not going through a bump, they seem to just be coming out of nowhere. And so the question came up, is there a dysplastic lesion in the anus that is not necessarily a wart? And that came through and brought about the concept of anal intraepithelial neoplasia, which is dysplastic changes in the skin of the anus that are not visible and they're not palpable. You don't know that they're there, you can't see them, but they're there. And it turns out that that lesion does exist. So then, just a little bit of terminology, because it gets very confusing when we read these papers. Cytology, when we look at a cell smeared off and look underneath the microscope, is graded as low-grade or high-grade intraepithelial lesion, squamous intraepithelial lesion, LGS. And that's very similar between the gynecologist and the rectal surgeons. When you do a biopsy, when you actually look underneath and look at the structure of the skin, then you can start talking about anal intraepithelial neoplasia. And they tend to grade it into grade 1, 2, and 3. Most people are getting away from that now, are just telling you whether it's mild dysplasia or severe dysplasia. They're trying to dichotomize it rather than have 3 categories. Severe dysplasia is the same thing as intraepithelial carcinoma or carcinoma in situ. If you showed a slide to a pathologist, there's no difference between AIN 3 or carcinoma in situ. It's the same concept, it's just severe dysplasia. The problem with this is multiple studies, which also I think is present in the gynecology literature, although I think they've gotten better with it with certain mechanizations and technology. But when you show a slide to 4 pathologists in a relatively busy place that know what they're doing, they're all educated pathologists, only 48% of the time do you have all 4 pathologists agree as to what the level of dysplasia is in these biopsies, whether it's cytology or whether it's a biopsy specimen. And as a matter of fact, about 2% of the time, the 4 pathologists will give the 4 possible different readings. One will say it's normal, one will say it's low grade, one will say it's moderate, one will say it's high grade. And so it becomes a little confusing when you can't get the pathologist. And we have to keep that in the back of our mind just when we're dealing with this, because a lot of the primary physicians or a lot of the HIV specialists will do multiple pap smears, multiple biopsies, and say, look, we're showing improvement because it was AIN2 last time, now it's AIN1, or it goes to AIN3. It may be a sampling error, maybe interpretive error. We have to be really careful about whether we're really making any progress there or not. How often do we see cytology in the HIV-positive patients? A lot. 14% of the patients in Palefsi's study, at that time, it's probably up to 20 to 30%. In a lot of the studies now, if you just do a cross-section random biopsy, we'll find dysplasia in the HIV-positive male's bottom. So it's a very, very prevalent. Not just the HPV virus, we're talking dysplasia now, precancerous lesions. About 50% of homosexual men that come to our practices to get surgery for something, lump, bump, whatever, will have dysplasia in their bottom. So very, very, as Richard said, scary and common thing. Let's skip a couple of slides, time. So a lot of us kind of sat around in the butt world and said, this is starting to sound a lot like the cervix. They're both HPV associated. They're both sexually transmitted diseases. They're both really, really common, HPV in both places. The precursor lesions are pretty easy to identify. You can do pap smears, you can do biopsies, you can find them. It's pretty easy. And they did something to take what was a really, really common cancer and made it a bit less common, and ours is going up in the world. And of course, what happened here was development of the pap smear. And so we turned around and said, well, let's do pap smears. So we started, now the pap smear has become a pretty common thing for HIV-positive men as an annual exam. As a matter of fact, the CDC in their guidelines for treatment of HIV-positive patients includes an annual anal pap smear to look for precancerous or cancerous lesions in the anal canal.